Hi everybody, I'm Greg Davis, one of the organisers of our road trip to Orange. I'm really looking forward to coming to Orange and spreading our message about the problems of high blood pressure after hypertension and pregnancy, and the studies that we're doing currently to look at the best ways of communicating that to women who've had high blood pressure in pregnancy, and also the people that look after them.
So the visit this morning, it won't take too long.
No worries.
The 3U visit's pretty simple. I'm just going to measure your body composition. So it's standing on the scales that calculate how much fat and muscle your body has.
Yep.
Then I'm going to measure around your waist, sit you back down, measure your arm just to determine which size blood pressure cuff to use, and then pop this blood pressure monitor on. It takes 3 readings.
Yep.
It's programmed to take the 3 readings with a minute's break in between, so you just sit quietly. Then I'll take your bloods. These are the 3 tubes that go to pathology for the testing, and the other 2 I take to the lab, and we will freeze some of your plasma and serum for research that we're going to do when we've got a whole lot of stored samples.
No worries.
We're really keen to present our research about the importance of looking after women after they've had high blood pressure in pregnancy, and also presenting our study, that mother's baby study, which is looking at the microbiome in women who are planning to get pregnant, and then following them through pregnancy and afterwards, and hopefully finding some factors in this which impact on high blood pressure and diabetes potentially in pregnancy.
Alright, so you're here today for your 12-month postpartum visit to the mother's baby study, which is really exciting. That just is going to pop up like around your arm, around your finger. So the thermometer will be checking on your arm. Have you ever told what variant you were diagnosed with? No. Have you received the maternal formation? Can I put this on your toe? That's perfect. See how big you are? Sure. 75 centimeters.
Really looking forward to bringing our research into the rural setting. I'd like to invite Naomi up here to do our acknowledgement of country.
Good afternoon. So I would just like to begin today by acknowledging the Wiradjuri people, the traditional custodians of the land on which we meet today, and pay my respects to their elders, past, present and emerging. And I extend that respect to all Aboriginal and Torres Strait Islander people here today.
Thanks, Naomi, and welcome to everybody here and everybody that's online. I'd also like to thank Madeline Tynan, who's the marketing director for Tynan Motors, whose idea it was for us to come out here into the country and bring our research out to the country and spread it around. Madeline's been a great supporter of medical research in our local area in South Sydney for over a decade, and worked closely with her, but my main claim to fame is I've delivered all her multitudinous grandchildren safely. I'm briefly going to talk about high blood pressure in pregnancy so that everybody understands what we're talking about. So what is it? It's blood pressure higher than 140 on 90, and women can come into pregnancy already having high blood pressure. You can have high blood pressure after 20 weeks of pregnancy. You can have preeclampsia, when you'll all have heard of preeclampsia, and I'm going to explain what that is briefly. But you can also get preeclampsia in someone who has already had high blood pressure. So what is preeclampsia? It's high blood pressure which occurs after 20 weeks of pregnancy, plus it has another organ involved. So most commonly the kidney, and you have protein in your urine, but the extreme is that you can get kidney failure with it. It can affect the liver and have abnormal blood tests. It can affect the blood system, and the platelets, which are the little cells in the blood which do clotting, can actually fall, but at the extreme you can actually have failure to clot and bleeding. The brain, it affects that, and with headaches, blurred vision, and at the extreme again, eclampsia or fitting. And it can affect the baby as well, so it can affect the baby's growth, can mean that the baby has to be delivered early to actually, for either the baby or the mother, and there's a higher chance of the baby being stillborn as well. So how common is it? So this is a quote from one of the international societies that looks at hypertension and pregnancy. So worldwide, each year preeclampsia is responsible for over 500,000 fetal and neonatal deaths and over 70,000 maternal deaths. So normally in our population, high blood pressure affects about 10% of pregnancies. There are about 300,000 births in Australia every year, so that's 30,000 women a year. And preeclampsia affects about a third of those. And usually the earlier it starts in pregnancy, the worse it's going to be. How do we treat it? We control the blood pressure with medication most of the time. We watch the mother and the baby very closely, but the only way to really treat it is to deliver the baby. So either the mother becomes more unwell and we can't control the blood pressure, or the baby is not growing and the baby becomes distressed. What are the risks after high blood pressure in pregnancy? And this is the area that we've really focused on in our research over at St George in Sydney. So women who've had high blood pressure in pregnancy, they have 3 times the risk of having ongoing high blood pressure. They have 2.5 times the risk of heart disease, 2 times the risk of stroke, 2.3 times the risk of cardiovascular death, 1.8 times the risk of getting a blood clot, 3 times the risk of developing type 2 diabetes, and 6 times the risk of getting end-stage kidney disease, which is pretty rare, but it's still obviously a lot higher. And the important thing is that risk actually increases over the time after the birth. So in this particular study, which was done here in New South Wales, after 5 years after the birth, the risk was 1.8 times. At 10 years, it was 5 times. And at 15 years, it was nearly 12 times the risk of having a serious event. So, women who've had high blood pressure in pregnancy are at an increased risk, and this risk rises soon after the pregnancy. Women who've had high blood pressure in pregnancy need to know that they have these long-term risks, and that is one of the reasons that we're out here. Health professionals who look after women need to know that women who've had high blood pressure in pregnancy are at increased risk, and that's another reason that we're out here. And these women need closer follow-up long-term to detect and treat these medical conditions, so heart disease, diabetes and kidney disease. And I just realised that I forgot to introduce myself. So I'm Greg Davis. I'm one of the obstetricians I work at St George Hospital in Sydney, where we're all based, and so my special interest is high blood pressure in pregnancy and looking at the risk after high blood pressure. So that's the little medical introduction. Now I'm going to invite Dr. Lynn Roberts to come up and talk to you about her story. Lynn has had preeclampsia in the past, and she and I have now been working together for an awfully long time. And so Lynn is a research midwife now and has a PhD from one of the aspects of this long-term study that we've been doing at St George, and is intimately involved in all our studies and has been working in this area for a long time. So, Lynn, over to you.
Thank you, Greg, and thank you for introducing me. As Greg said, my name's Lynn Roberts. I'm the clinical midwifery consultant at St George Hospital in research, and I'm really happy to be here today spreading the word about preeclampsia, which is one of my favourite subjects in the world. Driving to Orange this morning, I was stopped off at Lithgow and I saw one of those community notice boards outside a church, and it said, "Be like a flower." I can't remember the exact words and I wish I'd taken a photo, but it said, "Be like a flower, put up with the heavy rainfall, but let that water, use that water to let yourself grow. I've done it badly because I can't remember the words, but basically it sent me a message saying this is why I'm here. I'm here today to tell you about my preeclampsia story, how I got through it and how I've turned it around into something positive. So I hope you get that message from my talk. So when the pregnancy I'm talking about today happened quite a while ago, 1993, but the memories are still quite clear in my brain, something you never forget. I had been a midwife for quite a number of years before my first pregnancy, so I knew what I wanted. I planned a normal birth in the birth centre, so a low risk unit, no intervention with my midwife. I'd go home a few hours later and the midwife would visit me at home. But the wheels fell off that plan quite early. I did book into the birth centre, but in my pregnancy care it was discovered that my blood pressure was always on the high side. And because of that I was referred to have a 24-hour blood pressure monitor, which as the name suggests, monitors your blood pressure for 24 hours. It actually records your blood pressure every 30 minutes. So imagine wearing that. Needless to say, you get very little sleep and it's very annoying. But from that, I was diagnosed with essential hypertension, or basically high blood pressure with no obvious cause. And just before I hit 20 weeks in this pregnancy, I was commenced on medication to keep my blood pressure under control. Everything was going along fine. I was monitored very closely. When I hit 29 weeks, I was admitted to hospital. You'll just be in for a few days, my doctor said to me. We just want to fiddle with your medications a bit, maybe add another one. We just want to try and get your blood pressure under control. And yeah, okay, I can deal with that. I felt like a fraud because I was really well. I didn't feel there's anything wrong with me at all. And after I'd been in there a few days, I'd had many tests done. And what happened was my blood pressure kept increasing despite the increase in my medication. My blood tests were getting worse, so my kidneys and liver function tests were worse. I was now showing quite a lot of protein in my urine. On ultrasound, my baby was quite small and there were problems with the blood flow through the placenta, and so I was diagnosed with preeclampsia on top of my essential hypertension. So I was given steroids to help mature the baby's lungs because it looked like I was not going to make a term pregnancy or get anywhere near it. And then I'd been in hospital a week when I had a very rapid deterioration in my condition. In fact, the staff who were there said that I went downhill in front of their eyes, which you do hear can happen with preeclampsia. So my blood pressure reached 210 on 110. My liver was bleeding, giving me excruciating pain up under the right ribs. I was very agitated and restless and I was vomiting. The midwife came in to find me on the bathroom floor. Well, I did press my call bell for help, and then it was just all systems go. The next thing I remember is I looked up, my room was full of the medical team and midwives. One drip went in one arm with medication in it to bring my blood pressure down, a drip in the other arm to give me a drug to prevent me from having a seizure, lots of monitoring for my baby and myself, and in the midst of all that commotion, my husband had been called and he had arrived. This happened on a Saturday night, of course, always happens, most inconvenient time. So I was then transferred to the operating theatre and had an emergency caesarean section at 30 weeks. From the operating theatre, I was transferred straight to the intensive care unit, which is not a pleasant place to be. I don't have any photos of myself in intensive care. Remember, this happened in 1993, back in the day when mobile phones were the size of house bricks and certainly didn't have a camera in it. So we weren't in the habit of taking a photo of everything that happened in our lives. But I do have a photo that I just share with you that I think truly represents what it's like to be a patient in the intensive care unit. Now, this is Times Square in New York City. We all know New York City, the city that never sleeps. This is exactly what it's like to be in ICU. Lights on 24/7, people going in all directions doing all their stuff. Not car honking, but lots of alarms going off, constant noise. And to make that, it's quite uncomfortable. To make it worse, a nurse sitting at the end of your bed just watching you and your monitors, and also you're nursed naked. So not a very happy environment, but one that you need to be in when you need to be there.
So on day 3 after the birth, I was well enough to be transferred to the maternity ward. So it was just a little trip downstairs. After a week of the birth, I was discharged home, and I walked in my front door heartbroken because I'd come home empty-handed without my baby. What I did have in my hands though was like a handful of medications that I had to take 3 times a day for my blood pressure, but without my baby. Blood and urine test results were all back to normal by 6 weeks after the birth, and my blood pressure medication was slowly weaned down and reduced over a period of several months, but has never stopped, and I continue on blood pressure medication today. I had a baby boy. We named him Alexander. He weighed 1,280 grams and he needed to be on life support. So he was transferred from the hospital he was born at to a hospital who could provide that care for him. On day 3, when I was discharged from the intensive care unit, I pleaded with my doctors to let me go and see him. And after a few checks of my blood tests and that, they agreed to let me go. My family took me. In hindsight, I was not well enough to go, but mentally I needed to go. I always thought, what if my baby died and he never experienced the touch of his mother? So off I went, as hard as it was, and this is what I saw. I sat by his crib crying, apologising to him. The guilt was enormous. He was my little boy, fighting for his life because my body let us both down. I promised I wouldn't get emotional. Doing okay. So our whole world was turned upside down and round and round. Dinner conversation changed. This is what my husband and I talked about over dinner. What were his pressures like on his ventilator today, and how much oxygen did he need? What did his heart scan show today and his head scan? And what drugs did he have today? How was he going with all his drips? Did you see they moved his drip from his left hand to his right foot? Feeding, that was always, because I was constantly on the breast pump expressing. It just totally ruled our lives. Alex actually did quite well. He had a normal, typical path of a preterm baby, and he came home 46 days old, so still a few weeks before he was actually due. He weighed just over 2 kilos, and I'm really proud to say he came home fully breastfeeding. And I successfully breastfed him for 9 months till he gave me up, and I was really upset about that too. My life then changed again. I jumped on this merry-go-round where all I did was take him to appointments for physiotherapy, paediatrician checkups, development, eyes, ears, and feeding. The problem with having a tiny baby is they have tiny tummies and they need feeding frequently. So night turned into day and day turned into night, and I didn't know what was what, and we just went round and round. That's what I did. Always thinking that I needed to do anything I could for him to make up for the time that we lost together. When he was about 2.5, my husband dared mention those 2 words, another pregnancy. And I didn't think I was really ready for another pregnancy yet. I was struggling to get over that traumatic experience. We'd both had a life-threatening experience, and I just didn't know if I was ready for it. But what I did know that we needed some pre-pregnancy health care. So I made an appointment with my obstetric medicine specialist just for some preconception advice. And what he told us was, you've probably got about a 25% chance of developing preeclampsia again, but we don't know whether it will happen as soon or if you'll have all those really severe symptoms again. But we can also do a few things to help reduce those risks, and they are to be an ideal body weight before you fall pregnant, be fit and healthy, have normal stable blood pressures for quite a while before you fall pregnant, and this was to be controlled on a medication that I could take safely in pregnancy. And if I did go on and have another pregnancy, I'd be commenced on aspirin in the first trimester, because we know there's evidence that says aspirin can help prevent preeclampsia, especially the early onset ones. And my known history would be like a red flag. Everyone would be very aware of what to look for. I'd be very thoroughly monitored. And so my husband and I discussed this quite a bit. We decided that we would risk it all again. My medication was swapped to one I could take in pregnancy. It took several months before
My blood pressure was stable, I'd lost some weight, and we were happy to try again. So here's the good part of my story. I had another pregnancy. It was extremely well monitored, loads of ultrasounds and blood tests and blood pressure checks. But my second son, Lachlan, was born at 38 weeks, weighing just over 3 kilos, bit of a smallish baby, but typical size when you've got an existing blood pressure problem. And to me, I had a normal pregnancy, even though it was very stressful, and for myself and my care team, it was about as normal as I could get. And the other good news is that I had no change in medication throughout the entire pregnancy. I stayed on that very low dose. Totally different birth experience. Here I am, I did have to have another cesarean section, but here I am holding my baby in the operating theatre, and my husband was able to be with me this time as well, which he missed out on last time. So totally different birth experience. Here they are. Lachlan's about 3, Alex is about 7 in this photo. They were off to their cousin's superhero themed party. And it was about this time in our lives that things were starting to turn around in my career, and I was still struggling with the trauma of the birth. Alex had been diagnosed with learning difficulties and also some behaviour problems, who he was seeing a child psychologist for and a paediatrician. They diagnosed ADHD, so he was referred to a psychiatrist. And it was at the first appointment with the psychiatrist, where we were talking about his birth and his younger years, that I broke down telling my story and telling our story. And the psychiatrist said to me, "I feel like you may have had some depression after that birth, and you're certainly showing signs of PTSD. Did you seek help?" And I went, "Are you kidding me?" It was 12 months before I could take a step back and a deep breath and think, wow, what's just happened? No, I didn't seek help. And I said to him, "I feel I'm going okay now, but I just can't get over the traumatic birth experience." And his words, I can still hear them in my head today, were, "You don't need to get over it. In fact, you probably won't. What you need is to find a way to cope with what happened and move on and enjoy your life." I thought, well, that's very wise advice, but I didn't really know what to do with it. Until I was at work. This all happened really closely. I was probably at work that same week. I was caring for a woman in labour in the birth centre. It's about 3 o'clock in the morning, and in between contractions she asked me if I had any children. I said, "Yes, I have 2 boys." And her response was, "You know what I'm going through." And I thought, well, actually, no, I don't. I don't know what it's like to have a normal pregnancy or labour and a normal birth, and this was my goal, my light globe moment, where I decided this is what that psychiatrist meant to me. I'm going to turn my experience of preeclampsia around and make sure I help women who are going through the similar thing than what I did. So what I did, I left my role as a midwife in the birth centre, and I joined the RAP team, which is Risk Associated Pregnancy Team, which is a team of midwives and doctors who care for women through their pregnancy, labour, birth and afterwards. And these women have complications in their pregnancy, and most of them have high blood pressure. I found this role really rewarding, and felt that I could chat to the women and really understand how they were feeling about their pregnancy and the birth. I also wanted all my colleagues to be fully informed about what high blood pressure in pregnancy was, so I started teaching them at work, which led on to me teaching that subject at university to postgrad and undergrad student midwives. I started a support group up in Sydney. I held chat groups on the ward for the women who were admitted. We'd sit around and have a cup of tea and just chat through, a bit of a debrief for some and education for others. And I'd been on this RAP team for a couple of years when an ad went up for a 6-month secondment to do a research project, and the project was looking at the recurrence of high blood pressure in pregnancy. And I saw this as just another avenue to take on where I could learn more about it and help women a bit more, so I applied, and I was successful in becoming a researcher. Absolutely zero research experience, but I took on the challenge nonetheless. And like a lot of things in research, it took twice as long as what it should, and 12 months later we finished that study, and I went to Greg and said, "I really like research, do you think we can get something happening?" And so we did, and our research team has just grown over the years. My 6 months secondment has now turned into 20 years of research. Along the way, as Greg said, I've completed my PhD, which was on women's mental health and birth experience after having preeclampsia. And although my role now looks very different to a clinical midwife, I do feel that I'm making a difference in women's health. And just a quick slide to show you how our team has grown over 20 years from Greg and I and Professor Mark Brown, who started it all off. We now have over 20 members in our research group. This is an old photo, about 3 years old, because that's probably the last time we could meet face to face. But we're a friendly group. We meet every month, and we all look quite happy there, even though these meetings are at 8 o'clock on a Monday morning. And now we still meet, but via Zoom, and maybe one day we'll get back to face. We're also a fun group. We do things outside of our research roles. We celebrate World Preeclampsia Day. We've had an end of year fancy dress party where we all take it very seriously with our dress ups. And the bottom picture there is myself in the middle with 4 of our medical students from last year when we walked to raise funds for Australian Action on Preeclampsia. So back to me. Even though my preeclampsia was quite a while ago, it still has a hold of me. As Greg mentioned, we do have long-term health issues, and I'm pretty determined to reduce my risks of having a heart attack, getting diabetes, having a stroke. So this is a flyer that quite a few of the research team worked on with the Heart Foundation. We do have some copies up the back if you'd like to take one. Just simply explaining the risks that women have after high blood pressure. And so the recommendations that I take on board is that I do regular exercise. I do walk my dog every day, although we've had quite a lot of rain in Sydney lately, and I can cope with not walking, but my dog doesn't. She's the one who gets me out the door most days. I certainly try to eat a healthy diet. I continue on blood pressure medication. I see my GP at least twice a year to have my blood pressure checked. I have my kidney and liver function checked every year, as well as my cholesterol, my insulin and my sugar. And for the last 3 years, I've been seeing a heart specialist just for a checkup every year. And I'm pleased to say that everything's checking out okay so far. So just to finish up, an update on my boys. Alex is an arborist and loves caring for trees. Lockie's a licensed electrician who specialises in commercial fire protection. But to me, they're just my superheroes. And I thank them for giving me permission for using their photos in this presentation today. Thank you. I made it.
I think the last time we heard Lynn give that talk was at another meeting, and most of the audience was in tears too, including me. I'd like to introduce Associate Professor Amanda, who is worked with us at St George for how long now, Amanda?
10 years.
10 years, and trained in Sydney, and is what's called a clinical academic, so she's employed by the university. Those of us who are what are called conjoint appointments have a much easier path getting professorships and things. If you're employed by the university, it's really tough. So Amanda's been working as part of our unit and been working with us for all that time. Amanda.
Thanks, Greg. Hello, everyone in the room and online. So yes, I'm an obstetrician, but also, yes, a researcher and educator with UNSW and at St George Hospital. And I'm just going to quickly kind of follow up on our work around preventing heartbreak after having high blood pressure in pregnancy and a few sort of practical things. So I should have made the first slide, risk is not destiny, because that's actually the message. So, you know, the increased chances of things happening that Greg talked about, it's not inevitable that they will happen. And a big part of what we are trying to do is make sure that women and their healthcare providers are aware and therefore have the opportunity to ensure that risk does not become destiny. So in terms of what's recommended, various both Australian and international organisations do recommend heart disease and type 2 diabetes risk assessments after high blood pressure pregnancy. pregnancy. Problems include that the traditional ways, the things that GPs have in all their surgeries online to calculate risk perform quite poorly in younger women. So basically almost no woman who is before the age of menopause would show up as being high risk, in inverted commas, for heart attacks or strokes. Now high risk means like 10 to 15% chance in the next 5 years that you will have that event, which, you know, that's quite high really when you think about it to call high risk. Most of us much lower chance than that, but over time the risks stack up, as Greg showed. Look, we're still collecting evidence in terms of what works best, and we've actually just finished recruiting into our blood pressure postpartum study, which is looking at different methods of follow-up and lifestyle in the first 12 months after a high blood pressure pregnancy. Not going to speak further about that today, but just to say, you know, we are still working out what is the best. But we know that at a minimum, we do need to check risk factors and look at weight, blood pressure, blood sugar and cholesterol, and give women lifestyle advice. So the photo here is of now Dr. Heike Roth, who is an academic midwife at University of Technology in Sydney, and who I had the pleasure of co-supervising her PhD. And she basically spent her PhD looking at in Australian women and their healthcare providers, so including obstetricians, midwives, GPs, what are the knowledge gaps around health after high blood pressure pregnancy, and how can we close them. So we actually found very similar things in terms of what women wanted and what they perceived the gaps were, and what their healthcare providers would like. So that's actually, you know, reassuring in a way. Basically, both groups had sort of moderate knowledge, but lots of gaps when we were talking about something that wasn't just preeclampsia or other forms of blood pressure in pregnancy, and very little understanding of interrelationships such as heart disease, diabetes, and the high blood pressure pregnancies, and very little understanding that the risks actually do start to go up, you know, not just when you're in your 70s or 80s, but within 5 to 10 years after a high blood pressure pregnancy. Women told us they wanted knowledge in that first few months, but then boosted later on when they felt able to process. And I think Lynn very clearly has demonstrated how in that immediate aftermath it's really hard to process. Women were very keen, as are GPs and healthcare providers, about having both written and website information to supplement or to help with counselling from the healthcare provider point of view, but agreed that they want the healthcare provider as the main conduit. So, you know, we all still want a real live human being to come and talk to and know what to do and what to advise. Women do want knowledge about their children as well as themselves, risk-reducing information, and both groups wanted much better structured follow-up. So we kind of have a bit of a, I guess, post-birth black hole for lots of things in our community. We've kind of got the silo of the hospital and the pregnancy care, and then the silo of the community care, and we just need to work much better at linking those two up to help women's lifelong health. So now we are embarking on a pilot program to try and close those gaps, and additional centres, including if there's a demand in Orange region, we would be very happy to have on board. So the women's program that we've already started, women can enrol any time at St George and about to start at Liverpool Hospital as well, can enrol any time in the first 6 months after a high blood pressure pregnancy. Women do a baseline knowledge survey and then follow-up surveys 6 months and 12 months after birth. They get access to a post-high blood pressure pregnancy health-specific website that we've created, and an app that one of our collaborators, Claire Arnott, who's cardiologist at RPA, has built. They get reminder letters, SMS and email at about the 6-month mark in terms of saying, hey, it's time to go see your GP to talk about your health, and their GP, their nominated GP or GPs, get sent Heart Foundation information access to the website, and we're also planning to interview women about their experiences and what they think of the program. And this is just a little screenshot of the sort of the front page of the website, and the topics sort of listed there that we go through. And then just in terms of quick tips, because of course, you know, we can say, all right, lifestyle change, you know, you lose weight, don't smoke, eat well, exercise, and goes, yeah. But how do I actually manage to do that? So look, healthy lifestyle improves your heart health, but we get that it's often hard, especially when juggling young family and work and life. A couple of potentially just practical things. So Professor Claire Collins, who's a dietitian at University of Newcastle, has a website, nomoneyNoTime.com.au, which has got, for all of those who have no money and no time to eat healthily, with lots of low-cost recipes. And in terms of exercise, I think it's really important, regularly, not seriously, as little as 20 minutes a day in the lead up to getting pregnant, and or early in the next pregnancy will reduce the risk of high blood pressure by up to half, which is huge for a relatively little thing. And then just for general lifestyle help, New South Wales Health actually offers free telephone-based and web-based lifestyle behaviour change counselling, the Get Healthy service, which can be over the phone or online. And thank you very much.
Thank you, Amanda. I'd like to introduce Professor Emad. Emad's a gastroenterologist and was lured over here from Aberdeen to set up a microbiome research centre at St George Hospital, and has been involved with over 100 different research projects involving microbiome in the gut. So he's a gastroenterologist, studies the gut, and he's also the editor of Gut, which is one of the foremost gastroenterological journals in the world. So it's a bit of a change from pregnancy, but it is related to pregnancy. Emad.
Thanks so much, Greg, and good afternoon, everyone. It's a great pleasure. Just like to thank Madeline for making this opportunity to come and visit beautiful Orange and engage with the community here in rural Australia. I think this is incredibly important. Just before I start, I think Lynn's presentation was really quite moving, and I think it just highlights the importance of two things. One is real life. These are the things that we all get hit with, and we have no control over them. You didn't choose to have preeclampsia. Just, this is your lot. The second is how important it is to actually do something about it. Do research to try and figure out how we handle that, how we manage it, how to prevent it. That's really our call in life, is to try and figure out how to reduce the disease burden in society. So that combination of real life, medicine, research, taking it back to the community is all what, this is what it's all about. And I'm glad that we're doing this here in Orange. So I'm a gastroenterologist, so no one is perfect. I'm not an obstetrician. I can aspire to be one. My wife and I have 6 children. I delivered one at home, so I have honorary kind of obstetrician experience, I guess. It wasn't planned either. It was just one of those things that happened. But if you just go back in history, this is Hippocrates. Hippocrates is the father of modern medicine, and he's the one that actually said that all disease begins in the gut. This is a guy that's very astute, because he recognized that the gut perhaps is in fact the root of all of the problems that we can suffer from. Certainly when it comes to your cognition and the way you're feeling and so forth, it definitely is directly wired, and it has a major impact. And I hope by the end of this talk, you'll appreciate that it's also relevant to pregnancy and its outcomes, and that's why we're doing all of this research. So basically, the microbiome, I'm sure you've all heard about the microbiome, and that word gets branded about quite a bit. Essentially, it's the microbiology, all the bugs that grow in and on us, trillions of them. Most of them are in the gut, but they're everywhere in the body. So they're in every conceivable, your skin, your internal organs, everything's got microbiology. And these bugs interact and have a major impact on our health. Suffice to say that, in fact, it's in terms of genes, that like we have the human genome, these bugs outnumber us by 200 to 1. 200 to 1 more genes from those bugs that grow in us. So quite obviously they're very important, and they produce a lot of metabolites, they produce a lot of chemicals that impact directly on our health. And they've been implicated over the last 20 years on so many conditions. So people look at people with depression, people with inflammatory bowel disease, with cancer, and there is a connection between what's happening in your gut and your risk of developing these things. And it's not just an association, there is a direct link. And in fact, this is becoming established now in medicine. So it's a very exciting new revolution, and there's a lot of interest in gut health and what we can do about it to try and prevent all of this disease. So this is why we're trying to engage, obviously, with the rest of the country to try and take this benefit from the research that has been ongoing back to the community and see if we can work together to try and reduce our risk of all disease. question is why and how, and this is where research is incredibly important. All of these things have been identified. If you're interested to figure out why something is happening in your gut, why bugs growing in your gut have an impact on pregnancy or risk of depression, or why you're feeling miserable, or your mood and cognition, it's all about that interaction between the outside world and the inside world. And quite often we're separated by some kind of barrier. So in the gut, you've got this gut barrier. So you swallow things, you eat things, they go down, they interact with the bugs, and then the inside of you is through that barrier. You've got to get through that barrier to get to the systemic circulation, go through the blood and reach all the organs like the brain and everything else. This is what it's all about. If those bugs are working for us because they're good and healthy and diverse, we end up getting a fine balance that protects us from all of these things. If it's lost for whatever reason, for example, you take lots of antibiotics, you eat really pretty horrible food, and you've got the wrong bugs growing, that barrier is disrupted, and you start to become leaky. So it starts leaking, and you start getting the wrong metabolites, the wrong chemicals, getting through to your circulation, going up to your brain, going to the different organs, impacting on things like outcome of pregnancy and risk of preeclampsia and so forth. So it's all about balance. If you've got the right perfect balance because you're doing all the lifestyle things, you're eating a healthy food, your microbiome will work for you. And in contrast, if you've got the wrong balance, it will work against you and increase your risk of it. So this imbalance thing we call dysbiosis. It's a kind of a convenient term, not perfect, but we use it. Dysbiosis means lack of balance. Those bugs are not really working for you. And there's always that kind of chicken and egg situation. Which came first? Where you kind of, did you screw up your microbiome because of your diet and life? It doesn't matter. At the end of the day, you've got a disruption of your microbiome and you've got this chronic inflammation that is ongoing and underpins most of the conditions that we deal with, most of human disease. And it's been like, that chronic inflammation is the root of all evil. It's not money. It's chronic inflammation. It just causes all of this kind of disbalance. And as I said, it just spreads everywhere. That's why it's relevant to the kidney problems, it's relevant to what happens in pregnancy, to the placenta, what happens in your brain and the rest of it, and many things impact on that one. Now, you might think, why are these bugs so powerful? Why are they doing all of this stuff? It's because they're little factories. All this genetic power that you have in this trillions of microbiomes are producing little chemicals, and those little chemicals are basically acting on receptors in your body, impacting on your some of them neurotransmitters, for example. This is the currency of communication with the brain. They're impacting your metabolism, your risk of heart disease, and so forth. All of these things are integrated. I'm just going to skip through that one, but just again, I highlight this kind of mood and cognition and mental health because it's such a powerful connection between the gut and the brain, and of course, it impacts on one of the outcomes that Lynn has mentioned. Is the mood changes, the depression, the postnatal depression, all of these things are extremely relevant to outcomes of a successful pregnancy or an unsuccessful one. So from that point of view, I think we now understand that link. It's kind of emanating from the gut. And again, there are things that we can do to prevent it. Serotonin is the name. This is one of the neurotransmitters. This is the feel-good hormone. And you can't put the feel-good anything without putting this particular famous song here, which is very apt. Now, many things impact on your microbiome. So how do you, from the moment of conception, in fact, in utero, certainly through birth, so the mode of delivery, whether it's vaginal or cesarean, will impact on your composition of your microbiome. Of course, food and diet is the most important one because it's what you feed your bugs. It's what you actually dump into your gut that will become their actual diet that they consume. And it makes sense, of course, if you feed it the right stuff, you'll get it to work for you again. Medications. I mean, we quite often think of medications as antibiotics, and that's what's going to kill all the bugs, the good ones and the bad ones. But in fact, even any medication also has an impact on those bugs. So we're starting to understand this through the research and try and figure out if you really need to be on that medication, how long you can stay on it, and so forth, to try and protect you from consequences of an imbalance of those medications. Now, the effect of the diet on the composition of the microbiome is very powerful. And when you look at this picture, you always feel happy because it just looks healthy, doesn't it? It's just a diversity of color, it's plant-based, it's just the good stuff, isn't it? Now, obviously, this is the opposite of that, which is a diet that is rich in red meat and fat and so forth. You know, life is about a balance, all right? So it's a case of trying to get the right balance. As long as you've got enough of those good things, that will work for you and try and hopefully encourage a healthy microbiome to develop. Now, as I said, it starts in utero. There's a lot of work on this, a lot of interest. How does the placenta and how does it interact with the microbiome feed to that baby? Does it, you know, develop this kind of preeclampsia and hypertension of pregnancy and so forth? This is a very exciting area of research. So just watch this space. Over the next few years, you'll find a lot of stuff being published on this one. Now, the big question is there any evidence now that you can predict the occurrence or the risk of something like preeclampsia or gestational diabetes? So could Lynn have had a test, for example, to predict her risk of preeclampsia? Lo and behold, and just literally in the last 2 or 3 years, we're starting to get that research coming back to us. And there is no doubt that now taking a stool sample, a poo sample, and analyzing it for the microbiome, you can actually predict if you had an increased risk of developing preeclampsia. It's almost like sci-fi stuff. But it's true. This stuff is coming through, and there is even more impressive work coming through for gestational diabetes, for postnatal depression, excessive weight gain, all of the kind of adverse outcomes you can relate back to something that is happening inside your gut and inside the rest of your body. Now, what's all this worth if it's not something that we can change? Okay, I mean, so we can talk about risk, we can talk about your genes, put at risk, but you can't change your genes. Luckily, you can actually have a major impact on the composition, the diversity, the function of the microbiome so that it works for you. The most powerful way is through diet. All the lifestyle things that we know, exercise. So Lynn, exercises every day because that is actually improving your microbiome, making it more diverse. There's a lot of stuff about prebiotics and probiotics, and I'm sure I'll get asked about this later, so I'll just skip that one. But there's lots of developments and lots of ways that you can manipulate your microbiome even before you fall pregnant. And I think we'll come to that next. Now, you probably heard about this in the news because everybody talks about poo transplants. Everybody know this? Yeah, it's very, very, very popular in the news. There's only one indication that is actually of proven value, and that's C. diff infection. But there are lots of clinical trials in almost every disease that humans know where we're trying to see whether giving somebody else's poo will work for you. Does it reduce your risk of depression? Does it reduce your, does it treat autism? Does it treat diabetes? All of the clinical trials are ongoing. I suspect until we sort out what we give, in other words, what format it is it just actually poo that we transplant some way, either top end or bottom end? Or is it some kind of the essence of that, put into capsules and, delivered in a much more palatable way? This is kind of the concept of the capsules, which I think has been, mentioned quite a bit in the news. And in fact, these actually work. They work a lot better than just, putting it through a colonoscopy and so forth. But it may not be poo. It may be the essence of like the consortium of bugs that are actually work for you and trying to make your health a lot better. That could become the answer in the future. But that needs research. It needs a lot of investment. It needs a lot of clinical trials to show that that is actually beneficial. Now, all the work that I've done talks about adverse outcomes of pregnancy. But what if we can actually predict that risk even before you fall pregnant? And Lynn beautifully outlined the importance of preconception health. Once you had the condition, you had somebody care about, you would go and monitor things. But what if all pregnancy, if you're planning a pregnancy, you're able to actually identify your increased risk by looking at microbiome markers? This is why it's so important to do the world's most difficult study. And honestly, it is the world's most difficult study, and that's to look at preconception microbiome. Because you're recruiting participants, and some of them are with us here today, and I'm delighted and I'm really so grateful to you all for helping us out. Because we want to do something about it. We want to make sure that actually you can reduce that risk even before you fall pregnant in preparation for that. And this is why, and Naomi, my colleague, will talk about this most difficult study, which we set up at St. George Hospital. This is at the Microbiome Research Center, and it's called the Mothers Babies Study. And I'll just hand over to Naomi and I to try and explain that to you. Thank you so much.
Thanks, Emmett. And I'd like to hand over to Naomi, who's the Executive Officer and Project Manager for the Microbiome Research Centre. What a mouthful that is. So she's going to talk to you about this study that we've been involved with for a long time, and we're partly why we're here as well, to try and recruit more people to the study.
Let me see if I can find my slides. There we go. So the Mother's Baby study has been up and running since 2019 now. We've got ethics approval through St George Hospital. We're also registered with the Australian Clinical Trials Registry. We actually have support from the Australian Breastfeeding Association, as well as we're looking at paediatric outcomes and the impact of breastfeeding on your microbiome as well. Just a little bit about myself. So I'm a nurse and a midwife. The running joke is I'm not a doctor. I also have my immunisation accreditation. This is me rocking PPE well before COVID was a thing, but that is to show that I can actually get on the ward and still do my clinical practice. So I guess the biggest thing that we're looking at is how preconception microbiome impacts on pregnancy outcomes. So it has been touched on a little bit already, but in terms of the microbiome in women's and children's health, it's really important from an intergenerational and then an inheritance through the mother's genetic patterns as well. What we've seen is that your microbiome is actually inherited not just from your mum, but from your grandma. So everything that they've lived through has then been passed on to your mum and is now being passed on to you and your children. We know that development starts well before we're born, and what happens to us will actually go forward and impact on baby in terms of their risk of developing certain types of allergies, their asthma risk, their obesity risk, and neurodevelopmental outcomes like autism. We know that preconception health is a critical indicator of pregnancy outcomes, so how healthy you are going into your pregnancy, the lifestyle you lead, the food you eat, exercise you undertake. We know that by managing these risk factors enables us to optimise outcomes for mum and baby, and that diet and lifestyle has significant impact on reproductive success. Now, what do we know about the pregnancy microbiome so far? So as Emad has already alluded to, the microbiome's already been implicated in preeclampsia, gestational diabetes, perinatal mental health, and preterm birth. I'm actually going to touch on all of these aspects from a really personal level later in this presentation as well, as I also had all 4 of these. We're also looking at in the study how antibiotic exposure, not just during the birth, but pregnancy itself, as well as mode of birth, can impact on the child's microbiome and their long-term health outcomes. In terms of preeclampsia, what's since been found out is that your gut imbalance may contribute to that development. And what they're finding is if you have a less diverse gut bacteria and increased presence of bad bacteria, that this has then been linked to changes in blood pressure, changes to the protein in your urine, which shouldn't be there, and then changes with your liver and kidney levels. What a recent study has also shown is that probiotics during pregnancy can actually increase your preeclampsia risk, and that's been published in the Cochrane Review as of last year. Gestational diabetes has been shown to have changes in multi-site microbiome, so not just your gut microbiome, but also changes in your mouth microbiome, your vaginal microbiome, and that changes early in pregnancy are associated with the risk of developing this later in pregnancy. Diet has already been proven to be a key aspect in changing that risk development, and being given probiotics absolutely did no good whatsoever. When we think about preterm birth, and we think about your microbiome being diverse, we actually want a stable vaginal microbiome, and that helps to protect that pregnancy reach term. They've found that preterm birth has been linked with differing levels of your vaginal microbiome, and that your ethnicity can actually impact on that microbiome and change the stability of that and lead to preterm labour and birth. There is a potential for a bedside test. A research group out of Imperial College in London has found a bedside test that can show your risk of developing preterm labour and birth and how high of a chance you will go into preterm labour. It's still very much in the research phase, and that was only discussed earlier this year, so watch this space for that. When we think of perinatal mental health and we think about the gut-brain axis in terms of the microbiome, there is an intergenerational role with perinatal mental health as well. What some of the research has shown as well, but actually impact on the breast milk composition and the changes in the breast milk microbiome. Women that have developed perinatal mental health, whether that be depression or anxiety related to their pregnancy, have also reported changes in the infant's gastrointestinal symptoms, and they've also reported changes in their allergic reactions as well. And one research paper has shown us that prenatal stress has been linked to changes in the developmental outcomes, so increase in autism and neurodevelopmental changes. So why is this all important? Well, once we're pregnant, we know how to manage these things, but wouldn't it be nice if we could actually manage these preconception, make the changes, and then reduce those risks when we're pregnant? It means we can have very nice low-risk pregnancies, and then we can also reduce those risks for children growing up. So that's where the Mother's Baby study came into being. It was came about to address all the gaps in the literature, and those gaps are that we need large studies. So this study is looking to recruit 2,000 women across Australia.
It needs to encompass preconception, and then it needs to follow the babies for a long time. We currently follow the babies for 2 years, but we're planning on following them through to adolescence once we get that research approval. What we want to find out is whether any of the early life factors, so any of those preconception risk factors, can impact on adverse pregnancy outcomes and the postnatal long-term health outcomes. We use telehealth, online forms, and Australia Post to make this in a nationwide study. We want 2,000 women and their babies, and we also are hoping to get partners as well. So far, we have about a 50% uptake in partners. We conduct a detailed microbiome and physiological analysis. We take samples from every single body site, so vaginal, stool, oral, skin, urine, and blood. We sample the partners at baseline with an oral and a stool test to determine whether or not they impact on conception. And once Bub's born, we then take samples on baby as well. To participate in the study, you must be a biologically born female and over 18. That's just for consenting laws. You need to reside in Australia for the length of the study, and that's just because these samples will not ship very well. You need to be planning a pregnancy in the upcoming 12 months, and that's just so we can have a really good understanding of what your microbiome is doing in the lead up to pregnancy. These are all of the different time points that we sample at. So we sample 3 monthly. We then sample through each different trimester. We take a sample on Bub at 1 week post-birth. It would be too cruel to make mum do anything that close after birth. And then we pair sampling at 2 months, 6 months, 1 year, and 2 years post-birth. I've already been through all of those samples. In terms of the other information we collect, if you're a participant on the study, I thank you so much for all of this information, but we collect information on your diet, your physical activity. We look at depression and anxiety. If you can make it to us, we also conduct physiological assessments. So we look at your height, your weight, your body composition. And we also do a medical surgical history. If you've been pregnant before, we ask about your obstetric history and any pregnancy complications that came from that. And then once you're pregnant, we then find out how your pregnancy's been going, what your birth outcome is, and any medications that you've taken during pregnancy. Because this study happened to be up and running prior to a pandemic, we then had to add on an amendment to see how COVID-19 actually impacts on pregnancy as well. Once Bub's born, we get most of the information from their personal health record in New South Wales. That's a blue book. So we look at their length, their weight, their head circumference, whether or not they're getting vaccinated, how they were born, how they've been feeding, their developmental milestones, any illnesses that they contract in that first 2 years of life. Medications should actually be up to 24 months. And then also whether or not they've been impacted by COVID-19. In terms of the current progress, we've got 476 participants recruited, 107 are currently pregnant, 104 babies have been born to date, so we're at 50%, which is amazing. We're 25% of the way through our participant recruitment, which is very good. So why are we doing this research? So I went into my pregnancy not looking much different to how I am now. I ate a really good diet. I was really physically active. I cycled nearly every day. And then at 25 weeks, I got told that I had gestational diabetes, and if I just lost some weight, I would be cured. And I laughed at the midwife, who had never met me before. I then had a bleed, my ankles disappeared, and I wound up in hospital over my birthday. And this was at about 35 weeks pregnant. And I thought, what the heck is going on? My insulin requirements had started to decrease. They were doing regular scans on my baby. They decided that I had pregnancy-induced hypertension, but I didn't quite have preeclampsia yet, so they let me out for the weekend, which was probably their biggest mistake. So then I came back, tail between my legs 3 days later, blood pressure through the roof. I think I was sitting on about 170 or 80 on 100, protein in my urine. I had 3 emergency calls overnight because I could not get on top of my headache or my blood pressure, and they decided that I needed to have my baby. So an emergency cesarean later, thanks to a failed induction because my body just didn't want to cooperate, my daughter was born. We thought, great, it's all over, placenta's out, everything will be fine. Everything was not fine. And so she wound up in the nursery. She had a blood sugar of 0.8, so she was on quite a strong dextrose infusion when she was first born. She also had critical cortisol levels, so she had no stress receptors. She got jaundice. Trying to think what else happened. She kept pulling out her NG tubes. It was a game. Every time I went down, it was in a different side. It was in her mouth. They thought they'd have to put an umbi line in. Not the most traumatic experience, but I had pre-existing anxiety as well. So on top of all of this, I then got a diagnosis of postnatal depression and anxiety. Every time I walked into the NICU, even though I'm a NICU nurse, I would burst into tears. It just was a lot to cope with. And it took probably about 12 months of me seeing a psychologist every week to get on top of those complications with my pregnancy. This is my almost 2-year-old now, who's not even bothered. She went from being on the 3rd centile to now being on the 85th centile for everything. But if anything could come from this experience, it's that if I'd had the potential to do a stool sample or a vaginal test or anything in that preconception period that could potentially have then told me, hang on, hold off having a baby for 3 months, 4 months, 5 months, change something in your microbiome, eat differently, exercise differently, whether or not it was something to do with the medications that I was currently on for my endometriosis, any of that, then it would have been a game changer. I wouldn't have had to have any of the interventions that I would have had, well, not any of them. It may have minimized the interventions that I would have had. I would have been able to go with my baby for those first few nights. I wouldn't have had the stress of waking up every 2 and 3 hours when I got her home to make sure that she was keeping her temperature, that she needed to be fed. That's just my fun pregnancy as an overview. And so that's why we're here today, because we just want to help all the women that have gone through this and try and find out what's potentially there. We're currently doing an interim analysis looking at the first 100 participants that have gone from preconception all the way through to a term pregnancy. And we're going to see whether or not any of their markers are indicative of any of the adverse events that have currently happened within the study. We're sitting at around a 10% GDM rate, so we'll be able to look at those in the first 100 women and whether or not any of those women have got the predictive signature that was noted in our pilot study. And if you want to know more, those are all our contact details, that's the website, and that's how you can find us on social media.
So, Emma's left his phone behind. So thank you everybody, and thank you all for listening, and those online. Does anyone have any questions? Emma, do you think, how close is it to, do you think that we might be able to do something about preventing preeclampsia and GDM? That Naomi's talking about.
Yeah, I think we're starting to get some really consistent signatures of these outcomes, which I think is always the start. You've got to define the signature that you would pursue. What would then ensue, I think, would be obviously we need to do it properly, so we do clinical trials, so you would try and do this prospectively. So that's why preconception is very important. No one has ever done this in preconception. So I think that actually will probably take 2 or 3 years to get some convincing evidence. But in the meantime, I think knowing that the microbiome is manipulable, you can actually do something about it. That there should really be a campaign to try and encourage not just in the context of pregnancy, but just general health. I think we have to have some kind of serious attempt to try to get people to look after their health and look after their microbiome, because the return is massive. Honestly, I think it has the potential to transform medical care. Certainly for pregnancy outcomes, for us, involved in this field, it's very important because that's the next generation. It's all about having a healthy next generation. And if that's what it takes to achieve this, it's worth every bit of hard work. I mean, it's seeing healthy babies like this is what really inspires us. Yeah.
You mentioned about taking, sort of probiotics. I know your thoughts on those, but can you tell anyone else your thoughts on taking probiotics?
Sure. So look, the concept of probiotics is valid. So there are bacteria in your body that work for you and they produce the right stuff. So these are probiotics. What I have a problem with is products on the shelves at the moment that are labeled as probiotics and everybody's encouraged to take them because there is absolutely no evidence that was produced to show that they're beneficial. There is some evidence, as Naomi has mentioned, that they might be even harmful. And it's plainly obvious because it's a potluck. I mean, we don't know whether these are the ones that you actually need, whether they're viable by the time they pass through your GI tract. So there's a lot of stuff that is unknown about these products. But if you can generate your own probiotics by having a more sustainable, organic way of growing them inside you by diet and lifestyle, and that would be a far better approach. Just to give you a little bit of hope, because I think it's a hell of a lot easier if there's a capsule that you take that has those probiotics that work. There is now a lot of work on what we call next generation probiotics. So these are not the usual suspects that you can buy off, like with, I don't know how many billion things in a capsule, but these are the ones that came through all of this hard work and research, tested in clinical trials and shown to be beneficial. For example, there is something called Akkermansia muciniphala, which is one of the ones that is like a poster child of the next generation probiotics that protects you against things like diabetes, obesity, metabolic outcomes. And you can bet anything, there's a lot of work being done on it behind the scenes because there's a commercial potential there. But there are other examples that are being developed at the moment. So we may still get there by having proper probiotics that could be taken in the short term. But in the meantime, a diverse plant-based food, fermented foods, these are very good to encourage your own, healthy probiotic development. Give them an infrastructure, give them prebiotics. These are the things that can actually allow them to feed on the right stuff. And it's that combination. I think there's some really fascinating work being done, for example, with the poo transplants. Okay, in certain conditions that works, like inflammatory bowel disease, it will work for a few weeks, for a few months. But what if you followed it up with a proper diet that is plant-based and does exactly the same job? A study that was published just last week has shown that this is actually a very successful strategy. So we're learning very fast. I mean, it's not going to take us 10, 20 years to find out if there's something that we can do. The rate of progress is incredibly fast, which is very encouraging, of course.
And also sign up to Mother's Babies so that we can actually find out what are the signatures that a tailored probiotic might work on, rather than the research we've had up till now that Naomi was kind of alluding to, which was kind of taking something off the shelf and going, oh, well, we think probiotics is a good idea, so maybe this will work with diabetes and pregnancy, maybe it'll work with high blood pressure, and it doesn't. So we need much more specific work.
I mean, we don't want to scare people off probiotics that are available. It's just, they're very expensive. And in all honesty, they were not put on the market with evidence base. They're food supplements. So they've not gone through very rigorous clinical trials. They may work. I have no idea whether they will or not. And it's, we're well-meaning. I mean, we're trying to do something good for our health. But I would just think that, I mean, for me personally, I would do it the natural way. I would do it the hard way and try and just adopt a change in lifestyle. And it's great. I mean, it keeps you, really, really fit and healthy, and, you've got very, very diverse microbiome.
Sorry, just to clarify, so you're saying like a tablet form is an A, and then yogurt, kombucha, other sort of fermented, like, what's the cabbage one?
Sauerkraut.
Sauerkraut,
Like
kimchi,
yeah. That sort of thing, what you eat.
Yes, absolutely. And currently, that's the situation. I think, these natural products that are fermented but also plant-based. I mean, not necessarily vegan or vegetarian. It's just that, increase the presence, the number and the diversity and the color of those plant-based foods. And the magic figure is 30 per week. That has come through a lot of work, a lot of research on population level. So I think that's, and it's not that difficult, by the way, to include 30 base things, whether it's fruit, vegetable, legumes, all the good things that will actually encourage the growth of a very healthy, diverse microbiome.
What about if you were taking antibiotics?
Yeah, very important question. Yes, so if you take antibiotics, if you take one antibiotic, for example, it's not the end of the world. Okay, it will wipe out whatever is sensitive to those antibiotics. But because of resilience, especially if you had a very diverse microbiome, you will recover. And in fact, we've just concluded a big study. This is in collaboration with our colleagues in Taiwan on a combination of antibiotics. So this is treatment for Helicobacter infection in the stomach. I don't know if you know about this, that causes ulcers. We usually give you a 2-week course of 4 drugs. Okay, now you can imagine that's a big. If you look at the microbiome, after 2 weeks, of course, it's kind of decimated because you've wiped out quite a bit. But within 8 weeks to a year, you've gone back to your pre-antibiotic. So, a one-off or a two-off, it's not a big disaster. If you're taking them a lot, especially during childhood, especially for the wrong indication, that's problematic because you're set the tone towards one that is going to be disruptive for the rest of your life. But you can always recover. So you take antibiotics, you maximize your chances of actually getting back to your normal, healthy, diverse microbiome, you'll be fine.
We have a few questions from online.
Sure.
We've got one from Becky, and it says, wonderful presentation, and is it possible to sign up for your study if I'm already pregnant with a second baby? That's probably for you, Naomi.
Unfortunately, if you are pregnant, it is too late for mothers' babies. And that's just because the preconception outcomes are so valuable. They haven't been studied anywhere else in the world. So that's what we're really looking at. However, if you're planning baby number 3, how do you feel about that, Prudence?
There's another person called Perla who is asking, how do you know if, this is probably for you, Imad, how do you know if we have had a poor or good microbiome?
Yeah, that's a great question, Perla. And I think that is at the heart of this industry that has sprung up about testing your microbiome. And you now could commercially send a poo sample to a number of companies, some of them in Australia. And they're excellent companies. I'm not, the science is there. The only problem is that it's done for an individual that is then compared to thousands of other people that have filled out a questionnaire. So I would say that the definition of normal is kind of a little bit imprecise, let's just say, as opposed to say what we do in a proper controlled study. Now, they may have some value in the sense that they could tell you, well, you're kind of really dysbiotic or you're actually average. But in all honesty, what tends to happen then is that they get this very sophisticated report, usually sometimes 50, 60 pages, and they come to my clinic. And I'm sitting there trying to kind of figure something out that I can convey to them that doesn't end up with saying, eat better, exercise, do all the right things to. So in all honesty, I think in the context of general health, it's probably less effective, less important than actually in the context of a particular condition or a particular disease or a particular, something that you're trying to prevent. I think this will continue to develop so that sometime in the near future, we will have far better tests that could become available, not just based on description of who's there, because that's the problem. It just tells you what bugs you've got there, and this is the ratio of this one to that one. Completely useless. That doesn't mean anything, because ultimately it's what they produce. And sometimes you could have a mix that would produce still some good stuff, and sometimes it would produce bad stuff. So from that point of view, it's all about what we call multi-omic. Omics is like genomics, metabolomics. All of these omics will be integrated into something that is far more effective using artificial intelligence. This is where we're headed. In other words, we would get all of these things and get a far better, more comprehensive way of assessing what's going on. And then that could be used in our clinical practice. Amanda could be running her clinic, or I could be doing a clinic, or whatever it is, and somebody comes in with a complaint. We take the samples, we analyze them. You put all the data into some kind of algorithm. It gives you a precision kind of individualized plan of what's going on. This is your risk. This is how you would need to treat it. These are the drugs that you will respond to. This is what you need to do in terms of your diet and so forth. So it's actually far more intelligent. We're not there yet, but this is where we're trying to get to.
Can I just ask, with the men joining the study,
Yep.
the benefit?
Any partner, it doesn't have to be a
come
man.
out as yet?
Any partner, doesn't just have to be a man.
Oh, sorry. Sorry. But is there anything coming out from that as yet?
For mothers' babies in itself?
Yeah.
Yeah, so the value of that one is that obviously, as Naomi was saying, the microbiome of the baby initially is mostly from the mum. But of course, it's exposed. I mean, the making of that baby was, a partnership between two individuals. So they've contributed. And we don't know how much of the father's microbiome actually gets into the act at the beginning. But let's say after birth, it's exposed to mom, obviously more than, dad and siblings and relatives and grandparents and everything. So it's, collecting all of that stuff. If you really want to figure things out, imagine what value you would say, actually going back even before you were, conceived, this is what you started out with. that would be really, really invaluable. No other studies ever attempted that, and I think that would be incredibly valuable. That's why, again, this study is the best study that could ever be done. Unfortunately, it's the most difficult study to do.
And one question that's very, probably you won't be able to answer, but do you think, in your opinion, coming to the country and doing this study, you'll see different results than you would see at Cobra in Sydney or in Sydney?
Madeline, this is the crux of the matter. This is so important. We don't want to get a snapshot of the eastern suburbs in Sydney and, you know, the healthy, from cities, because a dwelling like a city is completely different from the rural environment. There's a lot of good stuff that happens in rural environments that protects you. So to actually get a fuller picture, you really need to do everything. You need to cover every population, every geography, everything. And that's really the value of this study. It's national. It tries to reach out to every corner of Australia. I think
we have participants from every corner of Australia as well. So from small little towns out in far western New South Wales, we've got people from Cape York up in Queensland, we've got Western Australia involved, every single state and territory has been covered. We've got a really good cohort of participants who are from rural Australia, so that'll be able to give us some really good indication on whether or not where you live and the types of food that you get out in those areas will impact on your microbiome.
So, Naomi, if their doctors don't know about it, and how can they give them that information and ask, say they were going to Greg and he wasn't involved in the study, what do they do to ask to be involved in the study?
Hopefully they can find us. We're on Facebook and Instagram. If you just put Mother's Baby Study into either of those, it will come up with the study. Otherwise, you can always just look up the Microbiome Research Centre in Google. All of our studies are on there, including other ones that aren't pregnancy related.
And the quicker we get there, the more we will be able to get benefit out of it, because obviously you need to get, the reason why you do a large study is so that you avoid false signatures and false hope. You want proper answers to the question, and that's the power of the study. You've got to do a large study so that you can weed out any chances or confounders or whatever. That's why it's difficult. Yeah, just a footprint. So for example, a signature could be, the names of the bugs or the ratios, or so it's something that we define, made up of the composition of the microbiome. That's it. It's just it's like when you do a blood test and they measure your cholesterol, for example, and there's a panel, and these are the values that define normal. This is high. This is low. It's an equivalent kind of thing, made up of the the combination of things.
Of the different bugs in the microbiome. Yeah.
Correct.
Anyone got anything else? Looked after that baby extremely well, Julie.
Yeah.
Really great. Madeline, do you want to say a few words?
Hi, I'm Madeline Tynan from the Tynan Motor Group and also from the Michael Tynan Challenge. Just to give you a little bit of a brief on what the hell a car dealer is doing here and supporting research. My father started Tynan Motors 57 years ago, and we always believed in giving back to the community, so that we've always been involved. I've been on what we call the SSMRF, which is a medical research foundation, for I think it's 12 to 14 years now. And then my father actually passed away from cancer. When you look at this research here, maybe that could have helped him in what he's went through and what our family went through. I suppose in saying that, why we keep giving back is we just want to make sure that other families don't go through what our family went through. If we can stop that in a little way, then we're doing it right. And what these people have given up today, out of their, you can understand if you look at their qualifications, is just amazing that they've given us a day, basically, and a day and a half to come out to rural, and hopefully we can fold this in and we send it on to other rural areas. Tonight we've got different doctors from your area coming in here, giving up their time to learn about this, and then we'll have a really good networking session after that so that we can really push this out there and take it to another level. These doctors are just part of a massive big research section that runs out of St George Hospital. You'd be very proud of the work that they're doing and the time that they're giving up to give back to us as a community, and I thank them for coming up today. So if you want to join the Michael Tynan Challenge and come walking with us, any of our fundraising things we do, you're more than welcome. You'll see us on the website as well too. I hope you've enjoyed the day. I hope everyone online has really had a great day. And tonight we're really looking forward to taking this information to your local doctors and your local nurses and taking it to the next level. Thanks very much everyone for the day. There is things to eat and drink too down